Good afternoon, Miami.
Hi, Carlos. How are you?
Ziad.
How you doing?
I'm good. I'm good. Too bad that we couldn't demonstrate the previous case. Do you guys have any questions of the other case? Because we can. If not, we could move forward on this case.
We had a lot of questions.
Lot of questions, Carlos. This is John. And we didn't realize until halfway through that because you never would answer us, that it was taped. So everybody kept asking questions and you never answered. But now you can. The two issues, the two questions that came up initially was about dilating, whether really you should or shouldn't even pre-dilate because it causes injury to the vessel wall before you put your covered stent in. And then the other question was the length of the covered stent. Those people thought initially when you was getting ready to implant, it looked awful long for the lesion that you were covering.
Well, very good questions, John. Well, first question. I think predilation has been associated with aneurysm formation down the road. The thing is that we were not talking about real predilation with a large balloon. What we did is just to dilate a little bit using a 6 millimeters balloon just to allow for the passage of the sheath. So I don't think this kind of predilation is associated with some aortic wall complications. I don't think I would have been able to advance the sheath through that very, very tight partition, almost tetratic, if I hadn't dilated the lesion. So this is why I decided to do that coming from above, because it was a more straightforward shot. So this answers your first question. And with regards to the second question, the length of the stent. In fact, I don't know if you guys know the V12 atrium stents, they come in different lengths, 29, 41, and then it jumps to 61. I think I could have used the 51. This is what I've already recommended to the company to manufacture a stent that is 51 millimeters long. So I think if we had used the 41 millimeters, it would have been a little bit on the shorter side. That's why we decided to go for a 61. The atrium V12 does foreshorten a little bit, so we made some measurements in the end, and it did foreshorten to about 50 millimeters, to 48 more or less. And this way we were able to cover the whole segmental lesion. So anything else, John?
No, I don't think so. There was a lot of discussion, but it was a very nice result
Miami?
in the end.
No, Carlos.
Yeah, agree. We were very happy. Too bad that we...
The other question we had was
Go.
about the size of the transverse arch. Do you think that would require stenting between the left carotid and the left subclavian?
Very good question, Ziad. As you know, sometimes when we place a stent in the quartation, we unmask some gradient across the arch. In fact, we didn't see that. We came with our Judkins catheter. We did a pullback, and the pressure in the descending aorta and in the isthmus were roughly the same. So however, I do agree that that arch was on the smaller side for that patient. However, one must remember that the descending aorta at the level of the diaphragm measured about 13 to 14. So it's getting an arch that measures about 12 is not bad if you compare to the descending aorta. But we keep an eye on that. I think when you use longer stents, you might have some more hypertension because of the stiffness of whatever stent you use. But on the other side, I think, I don't know if you guys noticed, but the left subclavian, the left carotid artery was arising from the innominated artery, very, very close. So I think we do have lots of space for arch stenting in case we need down the road. But my feeling is just a feeling that the patient's going to be fine during follow-up.
Great. Go ahead and present the case, Carlos.
Okay, well, we have a very interesting case, I think more straightforward, but in terms of hemodynamics and physiology, I think it's very different. Can I have the first slide on the case, please, Williams? Okay, so next one. This is a 75-year-old woman weighing around 60 kilos. She's had fatigue and dyspnea on exertion for many, many years. She has hypertension, and she's been on beta blockers, aspirin, diuretics, and amlodipine. On physical examination, there's a little bit of hypertension, 150/90. There is a typical murmur of ASD in the mid-sternal border and fixed splitting of the second heart sound with mildly increased pulmonary component. Next one. So the ECG, amazingly, she's still in sinus rhythm, not atrial fib, and there is RVH. And on echo, both TTE, TE, there is normal LV systolic function, LV hypertrophy, and there is abnormal diastolic function, type of relaxation type. There was an increased RA and RV, the measurements, and the RV systolic pressure was estimated at 45, 55 millimeters of mercury. There was also some mild MR, and an ASD, we're going to see the pictures measuring 19/15. CT was not performed, and catheterization, this was done over 10 years ago. In fact, I made a mistake when I sent the data to the syllabus, and this was done in another institution. We were told that there were normal coronary arteries. At that time, there was a bit of hypertension, pulmonary hypertension, 50/20 with a mean of 30. And there was a little bit of increased left diastolic pressures, 18, and a QP QS at that time of 2.3. At that time, more than 10 years ago, she refused surgical treatment. Next one. And there is some change in recent story. This you guys won't find in the syllabus. From November, December, she started to have some angina. And we brought her to the cath lab at the beginning of January. So this was 3 weeks ago, less than 3 weeks ago. And there was severe stenosis in the proximal LAD and moderate stenosis in the first diagonal branch. So she underwent coronary stenting with excellent result. Can I have the next slide? So as you can see, there's a red circle, a little bit out of format originally. You can see this severe long segment stenosis in the LAD. Next one. There is also an apical aneurysm and conspicuous LV hypertrophy. Next one. Again, on the left you can see pre and on the right post-intervention. This is an RAO cranial. So very nice results. She's been on aspirin and not having angina anymore. Next one. So at that time, January the 3rd, this year, here in our cath lab, we got these hemodynamics. So as we see 8, this is the pressure. We had RV 70/15, MPA 56/20 with a mean of 35. The wedge was 15, LA 8, LV 140/15, and aorta 135/60. This was on spontaneous ventilation. This is an interesting comment. We measured QP/QS was roughly 2:1. The pulmonary vascular resistance, I made a mistake there, typo. It was 3 units with ratio systemic, pulmonary and systemic resistance of 0.12. Next one. So this was the ASD. Simone has much better pictures. Next one. And this is a 3D reconstruction. Next one. So the intended intervention here is ASD closure using a fenestrated Figulla device under general anesthesia and 3 DTE guidance. Before Simone shows some nice pictures, I just want to tell you that under general anesthesia, the pulmonary pressure was roughly normal. We had 35/12 with a mean of 20-something, 24, 25. And the wedge was about 10 to 12 as it was the left end diastolic pressure. So under mechanical ventilation, and everybody knows that this decreases the systemic resistance, we got better pressures. But these changed after we balloon tested the ASD. So let's move to Simone. Simone, can you show us some pictures, please?
Yes, sure. So this is just a four-chamber view showing RV enlargement. And this is the still the 0 degrees. We can see here the ASD. The septum, the posterior septum is very mobile, as you see here. And we measured in this view 15 millimeters. And here the same measurement when the septum moves to the left side. And there is a left-right shunt. And in 45 degrees, we see here the posterior septum, very mobile, and this is the hole. We have a little bit of aortic rim. Here we got 18 millimeters. Again, with the left-to-right shunt. Although mobile, there is no additional ASDs in this posterior septum. And here we got 18. Another long axis view. We see how large is the right pulmonary artery, SVC, and again, a very central and ASD. And then we got some pictures, some 3D pictures. So we see here, this is the mobile posterior septum. We can move this. And we have actually like this, okay, here. So this is the right atrial view. You can see here the ASD, IVC is here, and then we move up and we can see the SVC here, aorta is here. So every very good brims around the defect.
Can you show us the stent?
Okay, so we got some picture of the coronary stent, as you see here.
Just
so
some nice pictures.
Yeah, this is the aorta, this is the left coronary artery, and this is the left anterior descending, and this is the stent, and there's another picture here, as you can see, the stent in the coronary artery. This is just some curiosity.
So yeah, let's thanks, Simone. Let's open for discussion. How would you guys tackle this patient?
That's a great question, because a previous cath showed that she had somewhat elevated LVEDP, about 15 to 18. The wedge was elevated, and now under mechanical ventilation, the picture has changed.
Yeah.
So I would still proceed with balloon occlusion and measure the LA pressure or the wedge and see how high does it go. And if it increases by more than 5 millimeter mercury from baseline, then I would definitely suggest putting the fenestrated device. If it's not, then I will close the defect entirely. So I have two people. Joachim, you were first, so Joachim, go first.
Yeah,
Sorry,
actually,
Dietmar.
the first cath done under sedation, the wedge was 15, but the LA pressure was only 8. So I think this has to be, clarified, because if we believe the 15, I mean, it's definitely dangerous to close the ASD. If we rather believe the 8 and exclude pulmonary vein stenosis, which would be like reading those numbers, you need to exclude pulmonary vein stenosis. But if we take the 8, I think it should be, the test occlusion should be okay.
Yeah, I think these are important points. It's do
Joaquin,
people understand
this cath?
Sorry, Carlos. The issue here is left ventricular diastolic dysfunction, not pulmonary hypertension.
Hi, Carlos, Dietmar. Happy New Year. It's a very interesting case, and I want to.
Happy New Year, Dietmar.
Yeah, I want to convince Horst Sievert that I can give a talk concerning out of proportion pulmonary hypertension and interventional approaches. So I hope he will accept it, because this kind of patients are interesting concerning the hemodynamics and then the decision-making for stenting. And I think to use a fenestration stent is, not a stent, an occluder is fantastic. But I saw your numbers, and you have has shown 50 to 20 systolic and diastolic pressure, and the mean was 35. And you have had 15 millimeter of mercury shown as a left ventricular diastolic dysfunctional, let me say, left atrial pressure. And you mentioned 18 or 15 end diastolic pressure in the left ventricle. So all in all, would you use the transpulmonary gradient, the official one, then it would be out of proportion because it is higher than 50 millimeter of mercury. But if you are looking to the diastolic pressure in the pulmonary artery, you have measured 20, and you have 15 wedge pressure, or even left ventricular end diastolic pressure of 15, then you have not an out of proportion, it is an in proportion, it's only 5 millimeter of mercury. So only by this values, I make the decision, this patient can have an occlusion of the ASD. And you have now used anesthesia in addition, and that supported this idea or this measurement before, that you can close it maybe even without fenestration, but it is better to have it for, let me say, a hyper-responsive crisis after closure. So in all, I want only to mention that you have to look of the diastolic pressure minus the left ventricular end diastolic pressure or wedge pressure, and not the mean pressure at the first. And the second one, if you use an anesthesia, you have an additional good, let me say, testing procedure to find out if it is out of proportion or not. Could you follow? I don't know. I try my best.
Let's go back to the case. And I totally agree with Ziad. This is exactly what we did. We occluded the ASD with a balloon, not only because of a balloon assessment of the ASD in terms of size, but it's a physiologic assessment. And the pressure here in the cath lab, we had about 10. Let's change to pressure, guys, the monitor. This is the wedge pressure, guys. I have a wedge catheter down in the RPA. This is wedge. I'm going to turn the key, and this is the left ventricular pressure. So roughly the same, just above 10, right? So this is the baseline that we had. And Simone also did some pictures, took some pictures, and there was a significant change in the pulmonary vein Doppler after we closed the ST. So let's change for the echo pictures. Echo pictures, echo bigger.
Carlos, but that echo, is guys. In yes, anesthesia.
Okay, so this is the mitral valve.
Yeah, this is under anesthesia, that's right. She's under GA. Go ahead, Simone.
So this is the mitral valve inflow Doppler pattern, and we measured here the A wave duration, and it was 155 milliseconds. This when the ASD was still open. And here we had the pulmonary vein tracing, and the A reversal had a velocity of 25 and a duration of 137, so less than the A wave mitral inflow duration, which is what we expect normally. And then we closed the ASD with the balloon, and the pattern of the mitral valve inflow changed. And we have here the A wave duration of 187, and we move to the pulmonary vein Doppler, and we see here that it's longer, it's 211 milliseconds, it's longer than the A wave duration from the mitral valve inflow, which means that the left atrial pressure is high. So the pattern is different, and the measurements say that the left atrial pressure now is higher when it's closed than
Just
before.
show the balloon, Simone.
Okay, so yeah, we have the balloon. We measured about 21 millimeters. We got a 3D picture here, and I don't know if you want me to talk about that. And we measured the area of the balloon, and it was 334 centimeters square. And then we compared that with the area of a 20 1 millimeter device, which is 340, so very close. So I think regarding sizing, I think we are in the right decision.
Can we change to pressure? Ziad, I'm going to inflate the balloon again, just for you guys to take a look at what happens with the wedge. I'm going to leave on wedge. Pressure, please. Pressure, the monitor. So this is a wedge. So I'm going to inflate the balloon across the ASD again. I really wanted to do that live. Can you show picture in picture with echo? Echo, guys, you see? This is, I'm inflating the balloon. Rodrigo, why don't you do that?
Yeah, there's no question that you can see that the wedge pressure definitely increases to about 30, 32.
Yeah, go ahead. Yeah, you see it's 20 yet. It's 20. I made a mistake, a technical mistake. I lost wire position, but it's still, I mean, it doesn't matter.
What?
It jumped from 10 to 20, 20 something. I'm going to change the key here. You see the left-hand diastolic pressure around 20. Can you take that picture off? No picture in picture. Williams, no picture. You see? So this is 20. So this means that this patient has a lot of diastolic dysfunction.
I would agree with you, Carlos. I would say I would feel safer to close it with a fenestrated device.
I use. Agree. So any more questions?
We have a question from Dr. Akaji.
It would be nice to demonstrate live when we cross.
Go ahead, Taji.
Yeah,
Down when it
Akagi,
is.
Japan. It's a really interesting cases and also very important cases. I have two opinions. The one is that sometimes I experience for the discrepancy between balloon occlusion, the wedge pressure, and after the device, the placement. So that is usually not same. So of course, this is a high-risk patient, so I have no doubt about the fenestration. And second thing is this kind of patient is closure is not so difficult, but management before and after the closure is much more important. So I put in the wedge pressure Gans catheter from the jugular to monitored for the overnight in the ICU. So this patient have the diastolic dysfunction, also pulmonary hypertension. So that is a post-operative management is much more important.
Yes, I was going to add, Teju, we agree. Throat fog. And that is, we started seeing discrepancies between when we would balloon occlude in the elderly patients, our adult congenital patients, and what would happen. And then they would go on more heart failure meds, et cetera, diastolic meds, come back and then get recatheterized. And the difference when we would just put the device in and not release it, close the hole, and you didn't see as much effects as you did when you did the balloon, which then led us to change our practice to, instead of balloon occlusion, we go ahead, put the device in and not release it. We do all of the same measurements that were done, although not as beautiful as Simone did. We're not smart enough to do those kind of physiologic echo measurements, I think. But and then if in fact the pressures go up, we pull the device out and fenestrate the device since we don't have fenestrated device, and then put it back in. So we've stopped doing the balloon, but I think there's got to be some, because we found some discrepancies. You did the balloon, it didn't look so good. You put the device in, it was closed, and it didn't change. So I don't know the reason for that, but it's the same kind of thing.
One question?
Carlos, I'm Bharat. The question to you is that rather than
Yes.
closing the ASD straight away, what is your policy regarding preparing these patients with diuretics, maybe for a couple of weeks? Because my concern is that no matter how you fenestrate the device, the efficacy of this fenestration is, I'm not sure how good the efficacy is. So why not prepare the patient for a couple of weeks and then get back for the second time and then fenestrate and close the ASD?
Yeah, that's a very good, very good point. In fact, this patient had been taking some diuretics before. She's been in hospital for 2 days since Friday, having some IV diuretics as well. I totally agree with both comments. And Bharat and Teji, I think the post-procedure management can be challenging. I think we can leave a wedge catheter there. Just want to go over some pictures here, just to tell you what we have. This is what we have now. We have a catheter in the left ventricle, the balloon crossing the ASD, and a wedge pressure wedged in the distal RPA. So this was the balloon being inflated with all the catheters. We got roughly the same measurement Simone had, around 20 to 21. So the plan is to use a 21 millimeter fenestrated device. I can show you the device here, and I think Bharat's point was very well taken, but I have to make a comment. Let's show my hands, please. My hands, make it bigger, big screen, there you go. So this is the fenestrated device. Can you make it bigger, zoom? So it's not a fenestration that you create. It comes from the manufacturer. So, which is good. I think this is a 6 millimeter fenestration in a 21 millimeters device. We've had the chance to use this kind of device twice. One in a life case for CSI last year, and the other one for a child with a smallish RV post RF opening of the pulmonary valve. And in both occasions, the fenestration remained patent after 6 months. So this is not a fenestration that you create in the cath lab. It comes like that. So I think the likelihood of remaining patent is higher for these devices. So let's see what happens. I still have the wedge catheters in the catheter in the RPA. By the way, can you show here the groin? Aqui, yes, I have a catheter in the artery and 2 catheters in the vein. 7 French sheath, and now I have a 12 French sheath placed in the vein in order to deliver the 21 millimeter device. So please zoom my hands here. My hands, there you go. This is the way we load. So it's a coupling kind of mechanism. This is the Figulla 1, Figulla Flex 1, sorry. It's not the Figulla Flex 2. So when load this in this is a regular sheath, 12 French regular short sheath, the usual thing. Is it closed, the locking thing? So some flushing here, underwater. So I leave the sheath below 0.0 always, at all times. Of course, the patient is under mechanical ventilation, so positive pressure helps to avoid air entry in this situation. That's okay. That's okay. Just give me a syringe. Yeah. Just want to see some back bleeding here. Yeah. There is free bleeding from the side arm of the sheath here. So flush. I don't think the implantation itself will pose any technical difficulty here, but I'm really curious to see to check hemodynamics after this device is in place. Can you make the fluoroscopy bigger now, guys? So the device is well attached, fluoroscopy. There you go. Let's make the echo bigger and fluoroscopy smaller. I think echo is more important here. Echo bigger, please, guys. And then my hands, small screen, picture in picture. My hands, no. Fluoroscopy, sorry. Fluoroscopy. No. Echo bigger, fluoroscopy smaller. There you go. That's perfect. So what I'm going to do is bring the sheath from the pulmonary vein. So it's close to the left atrial appendage. By the way, there was no thrombus in the left atrial appendage. The velocities were normal. I think the device is open, the left disc. You see, sometimes there is this global shape of the Figulla device. It's because there is no clamp on the left side. All you have to do is sometimes is just push it against the wall, and you flatten out the device like that. Now Simone is going to show me the echo. Usually I use the short axis view to place the device. I think I have room to pull it a little bit further back. I'm going to rotate the device a little bit. Let me see something here. There we go.
Where are you now?
Yeah,
Here.
there. You see, I rotate the sheath clockwise in order to bring it parallel to the spine in the AP view, so that you bring your left disc parallel to the septum. So I think I'm in a good spot. I'm going to open up the waist like that and open the right disc in the right place. So there you go. This is something, using this maneuver with this device, I think the Figulla's device is more flexible. Using this sheath with a 45 curve at the tip, we don't usually use other maneuvers such as the left upper pulmonary vein, right upper, or a second catheter, or a Hausdorff sheath. Usually we keep it very, very simple. So let's see. I think the device is in place. Let's see if the fenestration is working.
Okay.
So you can see that there is some flow,
Carlos,
left to right flow across the fenestration. Can you make some comments? Yes, yes.
yeah, sometimes when I use a fenestrated device,
Yes,
of course,
Yes, go
man-made
ahead.
fenestration, I keep a guide wire in the left upper pulmonary vein, and I load the device through the fenestration and out the sheath, and this will ensure for me that it is central where I want it. When you deploy the device like this, the worry that the fenestration may not be exactly where you want it. Did you encounter any issue with the other two cases?
Oh, that's a very good question, Ziad. I didn't have any issues with the other devices, but I agree with you. One of the tricks I think that is very important with these fenestrated devices is not oversize. That's the thing. Otherwise, you're going to smash the central waist and you're going to smash the fenestration. That's why we didn't go for a 24 millimeter device. In terms of area, just to give you an idea, Simone had an area of 336 millimeters per square. We had the 21 millimeter device has an area, central waist area of 346. So roughly the same, right? And we use a very, very compliant balloon, the NewMed. We didn't overstretch. So, and I think on echo, it looks like the fenestration is open. Can you show us some 3D pictures? See?
Yeah.
Maybe on FAS, whatever you can get. And just while Simone does that, I've been checking the wedge pressure, and it's roughly the same. In fact, it increased from 10 to 12 to 13 to 14. So not much of a change. I think somehow this 6 millimeter fenestration is working to provide some runoff from the left atrium. I think it was a wise thing to do. You can see, Simone, go ahead to make some comments on these nice pictures.
Yeah, so this is a left atrial picture, and we see the device en face, and you can see here the fenestration. And let me move to the right side. Oops, sorry. This way. I took a lot of the gain out, and we see here clearly the hole, the fenestration. And
non-color, I think there is left to right.
Oh yeah, the color pictures were very clear
things,
here.
Ziad, about this fenestration, this is a custom-made device, by the way. Occlutech have been making these devices in a custom basis, and I thank the engineer, Hakan, I think he's in the audience, for providing us this fenestrated device. It arrived from Turkey Friday, thanks God. And one of the things about this fenestration is very close to the very central portion of the device, Ziad. So you gotta overstretch a lot in order to close this fenestration. And I think the device is in the right place. Let me show, before releasing the device, pressure on screen. Pressure.
Carlos, you just to know, you have
Williams
3
pressure.
minutes.
So this is with device. No problems, yeah. Just to show you, this is the wedge pressure. Remember, we had 10 to 12. Now we are having 13. I'm going to rotate the key. So left hand diastolic pressure, basically the same. So I think this fenestrated device is doing its job. So I'm going to do now is to release the device. Can I go fluoroscopy, please? Fluoroscopy bigger. Fluoroscopy. There you go. Before going to fluoroscopy, let me show my hands. My hands here. So this is the handle. My hand's bigger. Picture bigger here. Yeah, this is a safety knob. This red one, I'm rotated counterclockwise. So I'm gonna, this is like a bioptome, right, guys? I'm gonna release the device by just bringing these both parts away from each other. So let's go to fluoroscopy again. Fluoroscopy, yeah. So I'm gonna do that under cine so that you can see better. So sometimes it does not release. All you have to do is to rotate the cable a little bit so it's released. You see I had to rotate a little bit after the coupling pin was exteriorized. Let's see the final pictures on echo. Simone, please make some comments.
Okay.
Make the echo bigger. There you go.
So
Is the device in place? Let's see the fenestration.
Yeah, just have a look at the fenestration again. And if we take the gain out and we see clearly here the fenestration, you see here. And let's move to the other side, to the right side. And here we can see where the fenestration is.
Ziad, before we wrap up here, just want to show a very good friend of ours and of yours in the audience too. Please make the screen bigger here. We have Dr. Fontes with us here.
All right.
He just wanted to say hello. And you guys know he was a pioneer here in Brazil, and we owe a lot to Dr. Fontes. He's been a source of inspiration for all of us. And he came to the hospital on a Sunday to show his support and
do 2 cases.
That, he's here. I would like to thank my.
Yes.
Yeah, I did 2 cases, exactly. At his age, it's not that easy. But anyways, I would like to thank my staff. This is a Sunday, as you know. It's hard to make people work on a Sunday. And I'm glad that everything went nicely. Let me show you the last pictures on echo. The fenestration working just fine. You can see the high velocity jet. So I think we are done, Ziad.
Thank you very much, Carlos. Congratulations.
Congratulations.
That was excellent demonstration. And thank you for the entire team
See you tomorrow.
working on
See you
Sunday.
tomorrow.
I want to thank you and thank your entire team. I know how